Hey, good evening. Welcome to our third seminar on the lived experience of healthcare workers dealing with COVID-19 patients. My co-chair for this evening is Professor Sue Wong from Cardiff University. Let me go over the housekeeping. All attendees will be in listen-only mode. Please leave your questions in the chat sidebar. The questions will be answered right at the end. We will be recording the talks and you will be able to access these talks from our website, EMWWH.org. I'm delighted to welcome our first speaker for the evening, Dr. Ian Frayling, who is an esteemed colleague and a good friend. Besides many accolades, Ian is internationally renowned for his contributions to Lynch syndrome, which is a familiar cancer syndrome. Ian was infected with COVID-19 in the first week of March, and sadly, he has been a victim of long COVID. Without further ado, I invite Ian to share his experience of COVID-19 with us. Thank you, Ian.
Okay. Can you all see that?
No,
Not yet.
Okay. Okay, I've hit share screen. Is that working?
yes.
Yes, that's fine.
Okay. Right. Well, thank you very much, Mina, for that kind introduction, and thank you, Susan, for sharing this. It may get a bit emotional for me. It's not an easy disease, this one. I'm a doctor. I'm a pathologist. I concentrate on genetic tests, but I've also become a patient with a new disease, two new diseases probably. I put this up not to brag, but simply to show what I do. I'm an honorary consulting genetic pathologist to the major colorectal cancer centres in the UK and Ireland. I'm a senior clinical research fellow here in Cardiff. I'm president-elect of the Association of Clinical Pathologists. They seem to think I'm a good ambassador for things. I'm a member of council of what's known as INSIGHT, the International Society of Gastrointestinal Hereditary Tumours, and I'm also on council of the UK Cancer Genetics Group, and I'm also honorary medical advisor to two patient groups associated with Lynch syndrome. I need to apologise at the outset in case I've got something wrong, left something out, put something in I shouldn't have, or not mentioned someone. It's because I have specific lexical retrieval difficulty, which may well be secondary to long COVID. And I'll cover that as I go on. So what would I usually be doing? Well, what I hoped I'd be doing this year is going to many international meetings, seeing friends, writing textbooks. I'm an author for the World Health Organization on my specialist subjects. I would expect to be in the room talking with my friends in INSIGHT. That's our meeting in Texas some years ago. I publish things. I've even got into the Sun on Christmas Eve on 2013. And I'm also involved in the quality control of laboratory tests to do with the diagnosis of hereditary cancer. And every now and again, during major medical meetings like this one at Malta, I get to get some practical experience of things that go bang. Then it all changed. So let's start at the beginning. On the 3rd of March, I had a wound on my left knee and it was really inflamed. And I was worried it had got infected with bacteria. I had to put an ice pack on it. I wasn't feeling brilliant, bit of a headache. 2 days before, this is the picture I took in accident and emergency at University Hospital of Wales, where a very good nurse had just stitched it up for me. But if we go back a few more days, I'd gone into Cardiff on the 28th of February for a hearing aid appointment. And it transpires that on the 3rd of March, I became symptomatic with COVID, but that's only in retrospect. So when I attended A&E, I was worried about catching COVID, but I was actually maximally infectious, probably. So the timeline. So Mina may remember that we both attended the Rare Disease Day event at the Senedd in Cardiff on the week before, on the Tuesday. I checked up later and nobody seemed to have reported coming down with it as a consequence of going there, so that's probably unlikely. I think I caught it 5 days before because symptoms come on between 4 and 6 days when I went to Cardiff on the train. Ticket machine, train itself, ticket barrier. I then went to the bank, used an ATM, so it could have been all over the keys on there from people coming back from holiday. My audiologist neither developed COVID nor did I give it to her, which was good news. Then I had a sandwich, and we know that it can be spread on them. And then I went home on the train. So anywhere in between there and there, perhaps I picked it up. So on the Sunday, I gash my knee in the garden, and my wife takes me to A&E at UHW. And then on day one, in terms of the COVID, so that's 3rd of March, I've got this inflamed wound. I'm feeling a bit out of sorts, headache, mild fever. Not surprising, I've had 12 stitches and a tetanus booster, so I've got my leg up. And on the TV, there's only 2 cases of COVID in Wales at the time, 40 kilometres either side of me. So, you know, what's the chances of picking it up? And then over the next week, I get more and more fatigued. I go off food, I go off coffee in particular. Things taste strange, but I can still taste them. Burning sensation on my back that's curious, a bit like a 1st-degree burn, but no rash or redness. I sneeze once, but how often do you sneeze in a week? Slightly wet nose a couple of times after eating, so what? Bit of a strange, non-productive cough from within at night. And my wife decides to get sleep in the spare room, so she says, so that I can get some sleep. And I get my stitches out on day 9. And then on day 10, which is Friday the 13th, I take to my bed and commence with a really appalling disease, a bone-cracking fever, a worsening cough, and as a medic, I know I have to drink and cough for my life. And whoever was talking about this being flu-like has no idea. So I take to my bed on the Friday. I have this appalling headache still, muscle and joint pains like no other, unable to get comfortable, let alone pain-free. I've got this awful fever. I have to go and soak a bath towel in cold water, and I can almost feel the steam coming off it. And then I have to put on multiple layers to keep warm, and I've got painful blue feet. And it keeps on cycling through this every few hours. I don't want to take too many non-steroidals. There's reports they may be harmful, so I stopped taking low-dose aspirin, which most of me and my colleagues do, because we know it's got a good anti-cancer effect as well as other things. I have no appetite, total anorexia, but I know I have to drink. Curiously, sugar in tea tastes strange, but sweetener, sucralose, is fine. And that is a sort of a curiosity. I start rolling over, going on my side, my front, my side, my back every 15 minutes, appreciating that each time it makes me cough so much I almost pass out, but I know I'm probably keeping my chest clear. I feel faint on getting up. I pass clean out a couple of times going to the bathroom. And I have to ask myself, do I stop taking my antihypertensive, which is an ACE inhibitor? You know, is that making it worse, making it better? Who knows? I get confused, racing, disturbed thoughts. One of my hobbies is, or, you know, things I do is scuba diving. And I'm thinking, All I need to ask is for my wife to pop down the dive shop in Cardiff, 12 miles away, by the way, and get me a tank of 36% oxygen and everything will be all right. I keep on hearing people on radio keep saying it's only mild, and I keep thinking what I might do to them if I met them in the street. And then I keep smelling that my pillow there's cooking in it, and it can't anyway be unclean laundry, and I'm not going to accuse my wife of that. So how is the smell getting into the bedroom? And I think, well, maybe the flue from the cooker is blocked or something. So day 11 or 12 thereabouts, I notice a change in my breathing where I start alternating hypo and hyperventilating. And then in medical terms, that's called Cheney-Stokes. And it's an indicator of deranged blood gases and or your brainstem going bad. And that's frightening to realize that. It's subtle, but it's there. But it's still easy to move gas in and out of my chest. None of the reported difficulty breathing as described on the radio. So I think, well, okay, I'll hold fire. I don't want to fill up a hospital. I don't want to go to hospital if I don't have to. Might catch something else there, you know, all these thoughts going through my head. I'm frightened to sleep, but I'm terribly tired. I decide if it gets really bad, I'll need admitting and just have to admit to it. Very weak, terrible muscle and joint pains, especially like my sacroiliacs and my hips. And I asked my wife to put on diclofenac gel, and I think our daughter heard the screams down the other end of the house. So day 12, I managed to get up and go downstairs, holding on to everything. I've lost a phenomenal amount of weight, 7 kilos, as I reckon at the time, in 5 days. I still had no appetite. I say to my family, oh, are you going to work tomorrow? And my daughter replies, no, Dad, it's actually Monday. So somehow I have lost a day, and I still don't know where it went or how that happened. The next day, I've reached the end of my tether. I say to my wife, if it keeps coming at me, I'm done for. There's total rubbish being spoken on the radio. All this stuff about underlying causes, old and weak, be strong. Damn it. If you're being run over by a steamroller, you can throw all of that out. Yeah, it's very frightening. And I break down. This is not flu-like in any way. I ring my GP, and it turns out, I think, that I was her first patient. And talking to a medic did me a lot of good. And she said she was very grateful as well. It did her a lot of good because she had no idea what this all involved. So a couple of days later, I feel like something to eat. I manage a small bit. I've lost a whole load of weight. I struggle to wash. I can't lift my arms. I don't want to fall over in the shower. I managed to get into a bath. Then I've got the problem of getting out. I get dyspepsia, then irritable bowel with diarrhea for a few days. I'm not surprised. I'm starting to eat again after 10 days, but we now know that's probably COVID. I start taking some multivitamins because I just can't eat enough, and goodness knows what my body has used in a fortnight of fighting this disease. I hear about hypercoagulability, so I start taking my aspirin again. And my colleague, Dr. Esther Yaud, on the Welsh Council of the RC Path, posts this picture on Twitter, and it's a glomerulus in the kidney full up with blood clot, which is the red material here that's blocked all the blood vessels. And this is from a post-mortem sample of a patient who's died from COVID. So I'm thinking, is this how I've kept one side of the line? That I took aspirin before I was infected and it inhibited my platelets. Well, there's now a trial of aspirin in COVID being carried out through Newcastle. So this is even more frightening. I also start taking vitamin D again. You can ask about that later, maybe. So I tweet that I seem to have survived, and a friend in the business asks if he can send me an antibody test. And it arrives on a sunny day, the first day I've got out of the house, and the postman brings the package. And I rush inside, try to warm my fingers up. And I need 2 drops of blood, but I've got cold fingers. And then when I do stab my finger, the blood clots almost instantly. And I get 1 drop. And this is that test. And there are faint bands there demonstrating that I've had SARS-CoV-2 infection and I've produced a response, both IgG and early reacting IgM. And it only takes 2 or 3 minutes for those bands to come up. So is this the first positive antibody test in Wales? Maybe. My wife, who has had no symptoms, shared my bed and bathroom and nursed me without any PPE, test negative. And she drops the comment, some people may have pre-existing cell-mediated immunity due to previous infections. But then she would say that. She's Professor of Cellular Immunology at Cardiff University. So over the next 2-3 weeks, I start to get some muscle back in my legs. I'm under no illusion it will be a long haul. It took me a year to get over glandular fever 10 years before. Curiously, after the fevers stopped, I was getting hot flushes during the day, really hot, and night sweats, waking up dripping cold, like I used to get when I had cholecystitis. And it's a sign of deep-seated infection, but I may take my temperature and I've got no temperature. It's puzzling, but eventually it fades away. I reckon I'm slowly recovering, so that's okay. And then I'm not so sure. I don't feel good. I'm weak. I have this profound fatigue, racing heart, short of breath, feel rotten. And my medic neighbour sees me over the fence and he says, Ian, you don't look well. And I'm actually glad he says that, you know, professional to professional. And I'm starting to wonder, am I having a relapse? Am I going to be left with chronic fatigue? And you expect to be depressed after an acute severe illness, but this is like adding on the frightening. So I took this screenshot from BBC Newsnight, and Professor Carl Hennigan was speaking from Oxford. And this was a very early analysis of symptoms. This is very early. This is like before the end of March, I think. And I've basically got everything here, except I haven't vomited. I haven't bled. I didn't get a rash, but I did get that funny thing on my back, which we now know patients do get paresthesia, strange sensations, and I haven't had a seizure. But I never did really have a runny nose or a sore throat or anything like that. So, you know, not everybody's the same, of course. So between April and now, I realise I seem to get better, then I go back down again. And at the start, it was sort of a week down, a week going down, a week down, a week coming back up. And then it would go around the cycle. And I realised it was doing chronic relapsing. So I could sort of pace myself, realising that if this disease wanted to do this, it's just going to have to work its way out. And it might take a long time. So somebody on Twitter mentions that this seems to resemble chronic fatigue. And I look it up on the NHS website, and I seem to have most of what's going on. Thankfully, I don't get headaches with it, because the one that was associated with COVID was absolutely horrible. I've not noticed a sore throat or sore glands, but it mentioned problems thinking. I suddenly realised, yeah, I was having slow thinking, and somebody had been calling this brain fog. I wasn't getting flu-like symptoms at all. I did get occasional dizziness and sickness. Waking up in the middle of the night, like with seasickness, but I wasn't moving. And absolutely with the heart palpitations and getting totally out of breath, doing nothing. Just packing a bag in the supermarket or doing my laces up, something simple like that. Anyway, the pandemic is bad. It's depressing. There's all sorts of idiocy and lunacy going around. There's thousands of people dying. I'm a doctor. I'm specialized in lab medicine and pathology. And the natural instinct is, how can I help? And of course, I realize there's many ways. So I've donated serum to laboratories and researchers developing tests and vaccines, because they need to understand how people have reacted and in what way, and whether they can get a vaccine to have the equivalent effect, both commercial and university. Here's some of my serum here. I extracted from one of these, I think, shown with a stronger response. And my response has gone up and it started to come over. Here's 3 different tests from different manufacturers, and they all show slightly different results. The one from the first manufacturer here, that would come up as fast as the liquid would traverse up here. These would take 2 or 3 minutes each at least before a band came up. And this has led to, for example, publications such as this, where they've been able to comment on, are we underestimating how many people have got SARS-CoV-2 from antibodies because of insensitive tests. I find I have very high level of antibodies, including specific neutralizing anti-receptor binding domain antibodies. And that's interesting to say the least. Here's a dilution experiment where out to 1 in 5,000 dilution, I still have just detectable antibodies. I think this is day 34. There's an announcement in Wales at the time about convalescent plasma therapy, and they want people to donate. So I put out messages saying, yes, I've got Sky Eye antibodies. You can have as much as you want, frankly. Nobody gets back to me about donating here in Wales, but on a Royal College of Pathologists webinar, opportunity comes up in England. I can get to Bristol, okay. Here's the link. And so I've ended up donating over 1 litre of plasma through the NHS Blood and Transplant Centre in Bristol. And here I am doing the deed just after the event, taken by one of the antibody angels. And afterwards, they ply you with a lot of food, which was just as well, because I found that the services on the M4 were shut and I couldn't get a burger on the way home. But if you can't read that, basically that much plasma is equivalent to about 640 calories. So you've got a perfect excuse to enjoy yourself. I also donated my B cells, the white blood cells that produce antibodies, to a company called Regeneron to help develop therapeutic monoclonal antibodies. In quotes, as it said on the form, as I recall, I can't be absolutely certain, but this was the gist of it. They were hoping to develop a product that could be given for those in the front line, those who need to shield, and those who cannot be immunized. Of course, recently, a certain gentleman on the other side of the pond has received the said Regeneron, $90,000 US worth, I think. And of course, we don't know how effective it is because it's actually being trialed in a double-blind clinical trial here in the UK. So he's been treated off ticket, as we say. It's interesting that, you know, this improved the financial position of the company. And it kind of suggests, with apologies to the late Spike Milligan, that I could say this in you know, response. It makes you think about what is informed consent. I'll just leave it at that. Doesn't seem to, anyway, right. Other ways of coping. So we baked a cake, and I had a sudden idea for breaking up some Kit Kats and sticking some Smarties on top, on the basis that this damn thing tried to eat me, so now I'm going to eat it. When I went to give antibodies at University Hospital of Wales, I went past my own old department, which is down here, and I went past the oxygen tanks. I always had an interest in them because I was responsible for health and safety. And the original oxygen tanks are here for a 600-bed hospital. And the physical manifestation of the pandemic was a quadrupling in the size of the oxygen stores, and that it had grown out over the pavement such that they needed a concrete barrier to protect it. So if you were looking down at the world from low Earth orbit, you'd see this construction as evidence of a pandemic having passed, or passing. Anyway, coping with long COVID. For me, it happens to be chronic relapsing. Some people are affected all the time. It's a gives me profound weakness, muscle ache. It's a vague ache all over. But because it is all over, the sort of totality of the pain is quite significant. There's fatigue. You know you can't even do something. You're not going to bother even getting off the settee. And you get phenomenal shortness of breath on minimal exertion. Absolutely panting away, short of breath. Your heart races away. You get tachycardia. I found that I get occasional sudden attacks of real irritability where I've been ashamed of myself. Shakes, weakness, and it's relieved by sugar. So am I getting hypoglycemic attacks? They absolutely fits the clinical bill. There's brain fog. You think slowly. You can't even think about thinking about things, which tells you something about how you do think about things, actually. Um, you know, somebody will send me an email, even if I can be bothered looking. I know I can't even, I haven't got the mental strength to open it and read it and certainly deal with it. Sleep disturbance all over the place. You go to bed completely tired, but you can't get to sleep and you're wide awake, and then it's all just, you know, all over the place. Lots of attacks of irritable bowel from top to bottom. Waking with nausea, seasick without moving, really unpleasant. The thing is that it's unpredictable. It comes and goes. And even when you're feeling good, you can suddenly drop to bad and vice versa. So I went up the stairs and suddenly my heart was beating, and I measured it, 146. A couple of days later, going into the local town for a haircut, slightly late, so I had to walk fast up the road. I did half a mile and my pulse had gone up ever so slightly to 82. Now, I can't explain that. Whatever's going on is affecting, you know, is changing very rapidly. Early August, I could manage a sort of a quarter mile out the house along the lane, and then utterly exhausted the next day. But a week later, I'm in the Yorkshire Dales, I'm doing 12 kilometers, 800 meters of ascent, and I'm fine. I feel a bit like I've done 12 kilometers, but I don't feel absolutely trashed. And I do that on multiple occasions and go mountain biking. Then I return home and I'm out shopping. And then all of a sudden I get the shakes, the fatigues, everything else. It takes me half a mile to get back to the car, and my wife has to drive home. And it's taken me now 8 weeks to get back to what I'd class as okay. How do you cope with that? You think you're over it and then you're not. I just take each day as it comes. Having had a few bad things in the past, you realize that if you see the dawn, you've had a good day. So I find many have been similarly afflicted long term on Twitter, including many doctors. And some are far worse than I am. And so we got together and we published this letter recently in the British Medical Journal on dealing with persistent symptoms of COVID-19 and long COVID. And it's free to the world, so you can go and read that via the link. Then, of course, comparing notes with people who are similarly afflicted, you realize you're not the only one, and struggling to find words, there are many people mentioning it. And I find Professor of Clinical Linguistics in Hong Kong, Louise Cummings, has got in touch with us about she'd like to study us because that's her academic discipline. And it actually turns out to be very helpful. She says, no, you're not suffering from early dementia, Ian, because you've got no reduction in lexical diversity. In other words, all the different words I use. It's just that you can't find the words. And I described to her how my garden tractor needed mending, and the cutter deck, it needed sandblasting and powder coating. And I said, I was in the shop and the two hyphenated double words were completely tangled up and wouldn't come out. But luckily the shop understood, and she said, yeah, she said, that's an absolute classic. So she interviewed me through Zoom, and she's keen to find other people who would wish to be studied as well. I find so many afflicted long-term on Twitter. So some of them have specific organ damage. So it's not just simple chronic fatigue like I think I have. You may have heard of a doctor on the TV who's had permanent damage to his heart conduction pathways. And there's other things. Natasha Mitchell, a journalist in Melbourne on Australian radio, has got a podcast here where she interviewed a number of us, and you can hear more there about long COVID. One of the doctors she interviewed was Nathalie McDermott, who studied Ebola and did her PhD on human response to that virus. And now she has been absolutely clobbered by long COVID. She has trouble walking. She's suffering perhaps demyelination of her nerves. She can't empty her bladder. She's affected in other ways. So this is a damaging, severe, dangerous, nasty illness. This is not something to be dismissed. The other thing you can do is form a group, and together with Welsh tenor Lee David Bowen, we've formed Long COVID Wales, which is part of the Long COVID group in the UK. And you can find Long COVID on Facebook and Twitter, and Long COVID's on Twitter as well. We've put ourselves forward to the Welsh Government to take part in co-production as part of Prudent Healthcare. Nobody's taken off the offer yet, but we live in hope. Helping long COVID. It should be diagnosed on clinical grounds, not a laboratory diagnosis of COVID-19. There's total misunderstanding on this, and it excludes many, many patients from getting help. There's funding in England for specialist clinics, all the different disciplines, at least these, there may need to be more. The condition needs to be counted, studied, heard, cared for, and not ignored. There are absolutely appalling stories of dismissal by doctors, people being told it's all in their head. I can assure you it is not, although the virus may have been there. I can tell you that for nothing. Probably more than one condition and or a compound, almost certainly related to what's known as chronic fatigue syndrome and myalgic encephalomyelitis. But how do we know without suffering it? It's an opportunity to help all of those afflicted with this general condition, whatever the cause. There's a thing called graded exercise therapy that can be used or prescribed in chronic fatigue, but it's actually positively harmful. If you force somebody to exercise when they're incapable of it, very dangerous. The condition is reportedly more common in older persons. We're not sure because it's not counted properly, between 5 to 10% of people who get COVID develop long-term effects. So that's serious in terms of morbidity. We're told there's one clinic in Wales, in Newport, fine. What about people who live in Anglesey or Bangor then? But it's only for those who've been admitted to hospital and have had a positive virus test. So as we stressed in the letter and to the World Health Organization, many with long COVID missed out on a virus test, like me, because I was too late to get it in the community and I was never admitted to hospital. And the severity of long COVID is relatively unrelated to the severity of the acute COVID-19. So this is a totally inappropriate, unfair restriction. Also, COVID-19 affects more men than women, but long COVID affects more women than men. So it seems to be a rather different beast, related to, but not an absolute consequence of. And doing some rough calculations, which I'm endeavoring to refine as my brain fog allows, I reckon the morbidity from long COVID is likely in the end to far exceed that due to COVID-19. So the excuse that we have to deal with all this now, deal with COVID-19 now and everything else can wait for later, I don't accept that. And it's fairly sobering to think if I had not retired from the NHS in Wales last year, I would have to now on the grounds of long-term sick. So just a bit now on immunity, if I may, just to finish off quickly. Immunity is by antibodies and cells. Antibodies are well known to wane in time, especially to coronaviruses. So a cold that you had 2 years ago, you can catch again this year, perhaps. What's known as cell-mediated immunity, CMI, is due to what's called T cells, and it tends to persist longer, at least relatively longer than antibody immunity. And it's desirable to get this when you vaccinate people. Studies show that most who've had COVID-19, almost all in fact, get CMI, but not everybody gets antibodies. And indeed, some people, as my wife predicted, have pre-existing CMI, presumably due to previous infections, perhaps with other coronaviruses. Tests for CMI need complex reagents because they have to be tailored to your individual tissue type. So it's not easy, it's very complicated, but many people are working on them. But it may end up being the definitive or at least the best test of having had COVID-19. The British Society of Immunology have issued some wise advice to study this condition closely, to take a multidisciplinary approach, and to focus on underlying biological mechanisms, etc. I won't dwell on it. This paper from the Karolinska Institute was recently published And it shows here, this little graph down here, you look carefully, here's antibody response in just donors who've not been infected, people who've been exposed to COVID, people who've had it mildly, and people who've had it severely. And T cell responses are more, are stronger than the antibodies in relative terms. So I'm probably somewhere up here. And it's an interesting point that if I am immune, why do I have to take heed of all this stuff that everyone else who isn't does? We might dwell on that. So now people are after me for my T cells and more serum. That's fine, they can have as much as they want. I was passed on a bit of an email that, from a US plasma broker. We can supply high titer immune serum up to $50,000 per mil. Well, I've already given 1,350 mils and counting. So you do the maths. What price altruism? And it's got me thinking, how are we going to license immunity? Are we going to do it like a yellow fever certificate, which I already have incidentally because I had to travel to South America via West Africa once? Do we have to wait until the population immunity gets up to 80–85%? Well, on the basis of current human behavior in the UK, we might be waiting forever. I don't know. Anyway, just to finish off, a couple of quotes. Barbara Melville Johansson on Twitter asked, if you could encapsulate your long COVID experience in one word, which would it be? And I replied, painful. And my wife rather well summed the whole thing up. You couldn't make this up. So, questions, please. Okay.
Thank you very much, Ian. We'll be taking questions at the end because
Okay.
Anissa is going to speak and Mina will introduce Anissa.
Yeah, sorry, Ian, I thought you were going to show another slide. Thank you very much. No, I'm sorry. Thank you very much for the comprehensive account of long COVID. It was a brilliant presentation, and I'm sure there will be many questions at the end of next talk.
Right.
So we'll proceed to the next talk. The next speaker is Anissa Nawaz, a critical care nurse in the University Hospital of Wales. She's done amazing work in nursing the COVID-19 patients in the critical care unit. And now I invite Anissa to tell us what it has been like to work with the very sick COVID patients in the critical care unit. Anissa, over to you. I think you have to stop sharing the screen.
Okay. I'm trying to work out how to do that.
If you go to the share screen, Ian,
Yeah.
and say stop sharing.
Okay, there's nothing there. Oh, I see. Yeah, yeah. Right, good.
Thank you.
Do you want me to share my screen now?
Yes, please. Yeah.
Okay. Okay. Sorry, I'm a bit slow with this. I've never done a Zoom meeting before, so.
You will be okay.
No worries.
Right. Is that it?
Yes, we can see it.
Okay.
Yeah. Great.
I don't know how to play this. A second, sorry.
You can just have it like a normal presentation, like a
Is that okay?
slideshow. Yeah, you can do a normal slideshow.
Okay. So my name's Anissa. I've been working in the intensive care unit in University Hospital of Wales for 4.5 years. But I think when the COVID pandemic started, none of us really anticipated how profound the experience was going to be. I remember when I first heard about the COVID-19 pandemic in the news, it just seemed like another complicated problem that existed on the other side of the world, and it would never impact my life or the lives of the people I know in any way. But never did I think that it would have such a profound effect on me personally and professionally. So it all started around March time in our unit, and over the course of 8 months I witnessed things I had never really anticipated witnessing when I began my nursing career. My colleagues and I were expecting that something significant was going to happen and the workplace was going to change quite a lot, but I don't think we could have really predicted how much it was going to affect all of us, both physically and mentally. So at the beginning of March, in our unit, only a part of it was dedicated to nursing COVID-19 patients. And each shift, there was a designated number of staff assigned to the area. But as the weeks rolled on, not even every day, every shift, the designated area grew bigger and bigger, and the unit eventually became overwhelmed with COVID-19 patients. And as ICU staff, we are equipped with the skills and the techniques to both cope with high levels of stress and to care for very acutely unwell patients. But I don't think we could have ever anticipated how our skills and our resilience would be pushed to the limits during this time. Just both the nature of the COVID-19 patients and the environment we were working in made our already difficult work even more physically and mentally demanding. As for the nature of the COVID-19 patients, they were generally profoundly unwell and experiencing severe respiratory failure. And consequently, these same patients were very difficult to ventilate. And we do have a number of techniques and methods and treatments that we use to help patients with such severe respiratory failure, but our usual techniques like proning and using nitric oxide were either not working or were having to be used for a lot longer period of time than we would outside of the COVID pandemic. And often patients would experience secondary complications such as multi-organ failure. And then as a result of that, they would have to often need interventions such as renal support and inotropic support to ensure that the rest of the body wasn't overwhelmed and could continue to function effectively whilst the body tried to overcome the infection. And during the height of, on normal we sort of call it pre and post COVID times now on the unit, because the way that we function has changed so much that pre-COVID we would have sick admissions and sick patients to look after, but there was never so many admitted at one time. So during the peak of the pandemic in Wales, the unit was just completely inundated with such patients, and we as nurses were often worked above and beyond the boundaries of our own profession to ensure patients were receiving the best quality of care and were given a fair chance to fight the illness. So during the initial, whilst the trust was kind of getting all of the staff and the multidisciplinary team fit tested and getting the appropriate PPE for them, and making sure that they were safe to work in the high risk areas, the nurses were obviously a priority in getting fit tested for the appropriate masks and PPE. So while we were waiting for the rest of the multidisciplinary team to sort of catch up with us and be able to work in the red COVID areas, the nurses were often having to take on those extra tasks as well. So we suddenly found ourselves to be working just as nurses and having support from the multidisciplinary team, to having to encompass the tasks of the housekeepers, the caterers, the dietitians and the physiotherapists, and we were having to cope the best we could without the extra support we'd become so accustomed to. And as well as the support from the wider multidisciplinary team being lessened during that initial period, the usual mechanisms that we used ourselves to support patients were suddenly taken away. We suddenly found that we couldn't offer face-to-face contact time with relatives. We couldn't use things like reassuring touch, or offering a kind gaze or a gentle tone of voice, because the PPE acted as like a barrier between, its communication was a lot more difficult, not only with the colleagues but with the patients as well.
Anissa, can I just interrupt you? Your slides aren't moving.
Oh, they're not. Oh.
Yeah, sorry about that.
Sorry. Did I not press? Oh.
No, sorry, you forgot.
I'll just use it I'll do it with my fingers. There's not many slides. Okay. Sorry, so slides show how many patients were admitted, first of all to the hospital within South Wales with COVID-19, and how many were specifically admitted to ventilated beds in critical care across South Wales. So sorry. Working within PPE was probably the most stressful aspect of caring for the COVID patients. It was just, first of all, it was difficult to convey the normal things, like feelings and emotions were difficult to convey through all of the PPE. Having to wear the heavy masks meant that you couldn't really convey your tone of voice or emotion. So working with the colleagues, it was often we weren't able to jest or joke or have banter, the things that would usually help us get through a difficult day. We weren't able to share with each other. And in terms of patient care, we weren't able to convey a gentle tone of voice or reassuring gazes or a comforting touch. A lot of the mechanisms that we use to help patients get through their day and to help us get through our day with our colleagues, it was just suddenly taken away, adding to the difficulty of working during the pandemic, which is another one of the things that we didn't anticipate. The benefit of working in critical care as opposed to some of the other units is that we were deemed as high risk because of the aerosol generating procedures we usually engage in. So we were fortunate enough to have a sufficient supply of PPE throughout the whole period of March up until now, and we still do. But it was kind of like working, it was a bit of a double-edged sword, that on the one side, we were grateful for having sufficient PPE to work in, but on the other side, working in full PPE was both physically and mentally exhausting, and it still is. The heat during the summer months was debilitating, and pushing through the physical discomfort to care for such sick patients was one of the most difficult things I'd experienced. I found that I was using all of my energy in work, and after the shift was over, I was totally depleted. Waking up for shifts, at the peak of COVID and still now sometimes, was so difficult that I would often struggle to get out of bed, even before shifts or just days when I wasn't working. And as well as being physically exhausted, I found I was experiencing anxiety, stress, frustration, a lot of sadness. So we witnessed a lot of sad things happen during the pandemic, and a fear of the unknown, really. And these feelings and emotions come in constant waves, and the emotional instability hasn't really stopped, because we're still, you know, if anything, it's more anxiety inducing, knowing whether there's going to be another wave as severe as the one that we experienced initially. So it feels a little bit like we've overcome a lot of it, because the COVID admissions have slowed down over the last 2 or 3 months, but really the anxiety of not knowing, or the fear of not knowing what's coming next, is worse. I would say it's worse than it was at the beginning of the whole period. But there are silver linings. And although getting patients to the recovery line was very difficult, and more often than not it was not possible, when it did happen, it was the feeling was unparalleled. It was seeing the reactions of the patients once they'd recovered and were, you know, leaving the unit, was satisfying in itself. But knowing that myself and my colleagues were able to facilitate the recovery was a feeling I'd never experienced before, and it was like the ultimate in job satisfaction. And although the overall experience has been and still continues to be difficult, it's just brought a lot of, you know, a lot of good things with it. It's made me more grateful for my colleagues from the multidisciplinary team, and not having to work without them being there to support the daily functioning of the unit and providing care to the patients was something that I didn't really know that I'd taken for granted, and I feel a lot of my nursing colleagues would agree with that as well. And there's, I think, I've not just in myself but amongst my fellow nursing colleagues, I find that I appreciate the skills that we hold a lot more. So if it wasn't for our resilience or innovative thinking and our resourcefulness, getting the patients and the whole unit through the pandemic would have been a lot more difficult. We found that a lot of times we were having to think on our feet and trying to facilitate the care, giving care as best as we could in very difficult working conditions. And another thing I find that I've acknowledged, not only as nurses, our value to the patients in our immediate care, but overall in society, making sure that you know, society and everyone living with us in this country is safe. And it depends a lot on how well we work in our environment, and how we utilize the resources that we have, and our daily tasks and how well we complete them really do affect not just the patients in our care, but the wider environment of Wales. So I think although it's been very difficult, and it still is very difficult, there's things that I don't think I could have realized about myself or about my colleagues unless something so drastic had happened. And last but not least, I found that the camaraderie between the nursing and the medical and the multidisciplinary staff has increased quite a lot. It's really, like, working through tough times has really facilitated us working better as a team. And yeah, it still continues. The difficult working conditions are still happening, and they're still continuing, and we don't know what's around the corner. I remember back in March, every shift was different to the last shift. There was different patients every shift. The way that the unit was functioning was different every shift. And it's anxiety inducing, not knowing whether we're going to go back to that or not in terms of COVID admissions. But I think this newfound camaraderie and the confidence that I have in my own skills as a nurse and my colleagues, I'm confident that we'll get through the next wave and make sure that we can be as well functioning and safe as possible for everyone.
Thank you very much, Anissa, for your inspirational talk and your dedication to your stressful job. And you're absolutely right that COVID-19 has facilitated camaraderie, connections, and a joint approach to solving problems. So we are running short of time. Over to you, Sue, for questions. Thanks again, Lisa.
Thank you very much, both to Ian and to Anissa, and for presenting different sides of what is really very difficult on a human level for many people. And I very much appreciate your sharing your experiences with us tonight. We've had some questions which Ian has been answering, but perhaps for the sake of those who aren't able to look at the chat because of being on the phone, Ian, there was the message about your hearing. Did you notice whether there was any change? I know you had already said that you'd been going for a hearing test, but did you think that it made any difference to your hearing?
Unmute yourself, Ian.
Yes, you're muted, Ian. Ian, you're muted. Yes.
Okay, can you hear me?
Yes.
Yeah, as to hearing, okay, so I have permanent hearing loss and permanent tinnitus. So I've not noticed any obvious change in my hearing in terms of acuity or worsening or lessening of that. So no, not for me. I think other people may have. Brings up an interesting question as to things that have stopped happening since I was infected. So you can normally expect a few kind of, spots, infected hair follicles every now and again. I realized the other day that I hadn't had any for months, but now I've started getting one or two. Also, I'm used to having a little bit of eczema behind my ears, a couple of other places, and that's just started coming back. So it may be that my immune system has been booted into such a high orbit that it's seen off all these other things which are symptomatic of an immune system which rumbles along. Don't know.
So I guess it's something that people may also have varied experience.
You ask about the negatives, it's interesting.
So a question about your really horrible experience that you've had. The question is, do you think horrifying experiences like yours should be shared more to try and persuade the public to behave responsibly?
Well, yeah, I think you perhaps have to strike a balance between frightening people unnecessarily, but actually frightening people necessarily. I helped an elderly lady in the supermarket because she was clearly struggling with life and wearing a mask and everything else, and she needed something from a high shelf. And I reassured her that I was quite safe, I was a doctor, etc. And I wouldn't want to increase the anxiety of persons like that. I would like to frighten the people who are stupid and dangerous. People who've stuck their head over my shoulder while I was queuing at the entrance to a shop and shouted to their mates inside. Now, I know I'm probably relatively protected against a second go with the damn disease, but they weren't to know that. And I felt like flattening them out on the pavement outside. That's a real tricky one. I think the message has to be got across in an intelligent way.
Yes, thank you.
Yeah.
To Anissa, were you frightened by your job during the pandemic, and how do you think that you and your colleagues can prepare for the re-emergence of this problem?
Oh, you are muted, Anissa.
Yes.
Hi. Sorry, I'm just having a look at the question.
The question was, were you frightened during, by your job during the pandemic? And how are you and your colleagues preparing for another wave of this, viral illness during the rest of the winter as it approaches?
So yeah, it was really, really frightening. I remember the first shift that I did during within the COVID zone. I had successfully weaned, and thankfully the patient did quite well and got discharged to the ward a few days later, but I'd weaned him off the ventilator and extubated him, and then throughout the day he continued to cough, and basically the whole day was just a lot of aerosol generated bacteria was flying everywhere. And although I was in full PPE, having only known about the disease so early and there being so much concern about it in the media, it was a really, really stressful and scary time. But as time's gone on, we as a unit have learned that we can trust the PPE, that it's obviously worked quite well because we've had very low rates of staff going off with COVID, even having worked in the clinical areas for so long. So that gives you confidence to continue on through the next wave. And then I think with the emotional stress of working in it, it's still, I think it's going to be difficult, but like I said earlier on, just the support that we give each other as nurses, and knowing that we have a sort of, it sounds horrible, but a shared trauma, and that you're not going through it alone is something that's going to get us through it emotionally, I hope. I don't know. We're still very much living in it in intensive care. It's still very much the same as it was initially, even though we didn't have as many COVID patients. So I don't know if that answers the question.
Thank you. There was a question about support for you and your colleagues. Do you have any access to counsellors or other supports that you can go to? Because this really is clearly very stressful all of the time, especially when you're on the COVID part of the ward.
We do. Our unit in UHW has a clinical psychologist as a member of the multidisciplinary team who works throughout the year full time. So when we do have sort of counselling and psychological support if we should need it. And one of our team members has started a little campaign sort of in-house, just to encourage us to check up on each other, to reassure us that if we need any sort of support or to talk about our feelings or anything, that we've got people designated on the unit to talk our feelings through. So we are quite well supported in that respect if we should need support.
Hopefully that will continue and that you will find that your experience will bond you together even more. There was a question for you, Ian, about whether you think a vaccine may be coming along and how long it might take.
Okay. There are many vaccines in development. I heard recently that the Oxford one seems to have a good response in all age groups, because early thoughts were that there would need to be different formulations for different age groups. So that's good. There may still be a place for different vaccines, because I'm no clinical immunologist, but not everybody can have vaccines or vaccination by the same route or agent according to their condition. There are individuals who have immunodeficiency, who it would be extremely dangerous to expose to agents, and they would be the people who would perhaps benefit from passive immunity, so antibody transfusion, the Regeneron product, for example. I have every expectation there will be a vaccine. It depends how quickly we can get it taken up.
Yes, thank you.
Mm.
And just coming back to the long COVID, you know, we are only beginning to hear about this and your own horrendous experience, and your research into other people experiencing this suggests that you clearly are very much not alone. How might there be better diagnosis and implementation of help for people such as yourself who are going through this really difficult, prolonged experience with
Yeah. Firstly, I think there has to be education, both of professionals and patients, because I saw a comment from somebody thinking that they might have some signs of long COVID. So often this can be a very subtle, insidious condition, so that if you've not heard about what it might include, you may dismiss what you've got as just being one of those things. So there are things that even I have, I would have just put to one side, but I suddenly now realize, oh yeah, that's part of this. So like I had a bit of foot drop one day for a couple of days, and then it got better. But other people have reported repeated neurological dropout. The being lost for words. You know, you just think, oh, I'm getting a bit old and I've had a bad time. But when you start finding out lots of people have had this sort of thing, then it becomes more significant. There is excellent advice from Professor Tricia Greenhalgh who wrote a BMJ article on the care of those with long COVID. We need to educate GPs, we and all doctors. We need to give support to GPs in the form of specialist clinics so that they can refer people on who are beyond a certain threshold of needing such specialist care, as with any condition. And we really need to stamp as a profession, and I think the General Medical Council here has a role, on doctors who dismiss this condition and chronic fatigue syndrome as something in the mind. You know, there's a very bad history here of people being dismissed. So I think the time has come when we get to grips with this, and a much more significant amount of money needs to go into research on this, which will benefit all these other poor souls who've been sent into chronic fatigue. Now, I have no doubt that with COVID-19, there are specific things on top of the chronic fatigue, as well as the chronic fatigue, if you see what I mean. And as Anissa will well recognize, there's side effects of having had a tube down your mouth for several days, weeks, and having been on ITU. So you could well have somebody who has components of all three of those effects, and they all need specialist care and people to look after them. If only to hear from somebody, yes, we acknowledge and understand what you've got. We're sorry we have no specific treatments at the moment, but would you be interested in trials for X, Y, and Z? I heard on Twitter that magnesium supplementation may benefit. And there are trials dating back from the 1990s of patients with chronic fatigue who clearly benefit from magnesium supplementation. And my way of thinking about all this is that I've tried not to look up the literature and see what other people have thought. I've tried to work it out for myself. And if you think that everything that, in all the ways I'm affected and other people are, you could link it together in terms of cells that work by depolarization. So muscle cells, nerve cells, endocrine cells, gut cells, your brain cells, immune cells. If there's a subtle derangement of depolarization, perhaps because there's not enough or there's too much magnesium either side or something either side of a membrane, that would be very subtle, very difficult to detect without electrophysiology at a microscopic level. But it could start to explain it all. I've been on magnesium supplements. It wasn't a magic get up and walk moment, but without doing trials, I'm never going to know whether I got better just because I got better or because I supplemented myself with magnesium. You know, it's such a simple thing, but for example, preeclampsia was a really bad disease when I trained as a medical student. And then they discovered all you need to do is that these ladies have got into a magnesium losing state, and you just give them a load of magnesium and they get, you know, wonderfully better. It would be nature having the classic laugh at us for missing something so obvious and easy. I don't know. I'm not claiming it's that. Other people have clearly got neurological and endocrine deficiencies, cardiac conduction defects, permanent sort of physical damage caused by this illness. So it's not simple. And if it was, we'd have worked it out long ago.
Well, clearly, quite a lot of work still needs to be done, not only on the acute side of things, but as we get more experience generally, there is very much more to learn about it. And thank you very much for sharing your experience, and thank you very much, Anissa, for your insights
thank
too.
you, Anissa.
It's been really great to hear from both of you. There's been a lot of appreciation to both of you on the chat, and we have saved the chat, and we can forward that on to you. But thank you very much indeed, both of you.
Yeah.
So can I just finally thank people who have helped me? So first of all, I'm grateful to both the speakers for sharing their unique experiences with us. I thank the lively audience as well. My thanks to Professor Su Wong for brilliantly co-chairing the session. And I also extend my gratitude to Divya, Ishrat, Doctors Academy, and the Learner Society of Wales for their support. Finally, thanks to many frontline heroes, in particular the healthcare and social care workers who have put their lives on the line to save others. Our tributes also extend to all the families who have lost their loved ones to COVID. And now, finally, to look out for our next lecture in this series on the 12th of January 2021 by Professor Jonathan Bisson. And he's going to be speaking on the impact of COVID on mental health. So thank you for joining us.
Thank you.
Stay safe.